So, hello, Dr. Douek. Thank you so much for taking the time to do this with me today. I'm so excited to connect with you and to share a case study of my thyroid healing journey. You've been my physician for the last couple of years, and I'm just so grateful for the journey that we've been on and the results that we've gotten. And so, we're going to go through it today. Before we start, I just wanted to give a quick disclaimer that I am giving Dr. Douek my full permission to talk about my case in every way. So, I'm, releasing HIPAA and all that good stuff. I'm giving permission and consent for all of this. So thank you so much for taking the time to do this. And I just wanted to start by and see if you have any disclaimers, anything that you need to say before we get started.
Well, I really appreciate this discussion. I'm looking forward to it, and thanks for including me. And I will say that your case, as you know, is really unique, and I appreciate your willingness to talk about it in this forum. But it's so unique that some of the things are not necessarily applicable to everybody's case, and I want people to know that. And then the other thing I probably should say is that things we'll talk about. These are my opinions. These are not opinions of UCLA or my employer. These are just sort of my musings. So
Okay. Awesome. So with all of that out of the way, I just wanted to start by, allowing you to give us a little intro about you, your background, what you do at UCLA, how you got involved in RFA and these non-surgical approaches. So would you share a little bit about your background?
sure. So I'm a radiologist, and part of what I do is interventional radiology. And yeah, I'm a professor at UCLA, and I've been here essentially for my entire professional career. And I did my training here as well, including my residency and fellowship here. And much of what I do is diagnostic radiology, looking at images and making conclusions based on the pictures we take of patients. But the other part of what I do is interventions, image guided interventions, including thyroid RFA. This is a small piece of what's a much bigger program, our interventional oncology program, and our ablation program in general, where we're doing ablations throughout the body. I have a specific interest in the thyroid, and so with a colleague, Dr. David Liu, started the program about a decade ago now.
Awesome. Yeah. So now we have your background. So just going to when we met. So fast forwarding. So when I met you, I believe it was between like May, June of 2024, and I came to you with an extremely large goiter, maybe one of the biggest. I don't know, I don't want to speak for you, maybe one of the larger ones that you had seen. And I had actually already gone through RFA once with another provider in 2023, in February of 2023. It had ruptured. I had had a lot of complications, a long journey with it. It had healed over, but then I was interested in continuing to pursue ablation and look into my options. So here I am in your office. What are your first thoughts when you're taking on a patient or consulting with a patient that is already coming from, let's say, a complicated or complex history?
Yeah, it's a good question. Well, I think you were referred, or a colleague that I had at another institution had referred you or had given me a heads up. So I was expecting it
Okay.
a little bit. And you know, I have a dual role here. I'm in a big tertiary care hospital. We're very used to seeing patients with complicated cases that are sometimes referred to the community for a higher level of care. And part of the reason we're here is because we're excited to do that. We're excited to see complex and challenging cases. But of course, nobody loves complications or orienting around complications. They're certainly inheriting somebody else's complications. So that said, it was really intriguing to me to meet you and to think about doing things that hadn't been done necessarily ever.
And so what really like made you say yes to it? Because I imagine some other physicians may have been like, I don't know if I want to touch that.
Yeah, and to be honest, I didn't know that I would touch on and um, a lot of my openness to doing this was you, frankly. I think we had a really thoughtful first discussion. Um, you had met with many folks across the spectrum of disciplines, including surgery and endocrinology. And so this was something that was well explored and well thought out. And it was not just me as decision maker. And really importantly, it was you. I think you really had good insight into one, that we were exploring territory that was a little bit new, and two, you had an understanding of that uncertainty and the risk that came with it. And you drove the discussion a lot, frankly,
I did.
and for the last 2 or 3 years. So yeah,
Well, thank you though for continuing to go along with it
yeah.
and being with me every step of the way and humoring my desires. I appreciate it. But what initial concerns would you have had with a case like me? Were there any like initial red flags or fears or concerns that came to mind initially for you?
Well, you had come and you had a rupture, a significant rupture, and so you were in the very, very small percentage of patients that have a thyroid nodule rupture, and most of those patients will go on, and it'll take some time, but that rupture will correct itself, will involute on its own and heal itself. And a small percentage of patients, that's not the case. It ruptures to the skin. That's unusual, and so you were the unusual of the very unusual. So we're dealing already with, a pretty unusual situation. Um, I'm sorry, what was your question? I lost my train of thought.
I guess, well, what were like the red flags, and what were the biggest concerns?
Okay, right, exactly. So we're already dealing with sort of an unusual and a complicated situation. And I guess the main concern would be just that. We know that nodule rupture occurs, or we think it occurs, because the capsule that encapsulates the thyroid gland is weakened with the ablation and has a rip in it, essentially. And so if you have a capsule that's not intact, is there a higher risk for re-rupture? So that's the main concern in your case.
Okay. And so since we talked through that and I already had dealt with a rupture and I was comfortable if it ruptured again, well, I don't know, comfortable. I was willing to take that risk. That helped you feel a little bit better about moving forward, that I as the patient was educated.
Very much so. The fact that you had experienced this, and it was, you knew very well and understood, and we had a lengthy conversation about how that might happen again.
Mhm.
And you were willing to do that, very, very much was part of the decision-making process for me.
So then at that point, we decided to move forward. We had kind of an idea of what might happen. I think at that point, we had talked about maybe, doing smaller RFA sessions, maybe like 6 to 7 RFAs. And so we scheduled the first one, and that was scheduled for July of 2024. And so going into that first RFA with me, what were your thoughts about that? Or were there any extra precautions that you took, considering that my unique case?
Yeah. Well, thyroid nodule rupture is not super well understood. We think it's some of the things I talked about. Uh, the, the thermal ablation compromises the capsule of the thyroid gland. And we think that there might be an inflammatory response that's occurring within the thyroid gland after ablation that causes some swelling of the gland. And some people postulate that there's bleeding that occurs after within the gland. Um, so with all that in mind, theoretically, in your case, I want to do a more conservative ablation. We didn't want to do something super aggressive where we would induce a super big inflammatory response. And so I think we approached it with, let's be cautious, let's go slowly, let's have a smaller and more conservative, lower energy ablation out of the gates.
Okay. Okay. So you were erring on the side of caution in different ways with that
Yes,
first
that's right.
iteration in a lot of
That's right.
ways. Okay. Yeah.
Exactly.
And I remember also, just from a patient perspective, I know this is about getting your feedback, but if I could just interject for myself, I don't know if you remember, but I was very nervous. I knew I wanted to do it, but I came in and I had some trauma from my previous experience that I was
Yeah.
still like sitting with. And I remember telling you, like, if I start crying, like it's just the trauma, like just keep going. It's gonna be okay.
Okay. I don't remember that, but I remember you doing very well. I remember you
Yeah.
doing just fine on the ablation. So
Thank you. Yeah. And I remember what you said. You were like, well, you're not supposed to be, if this is hurting you too much, I'm going to stop. Like, I don't want you to be crying during this procedure. And so you
yeah,
were very tender, not only to the physical constraints of making sure that I was physically healthy, but also to me as a whole being, as a patient who had gone through a very complex procedure. And so I just want to mention that if there's any, physicians or patients that are watching this for the future, that was definitely something that was really helpful on my end, that you were reassuring me of how RFA is supposed to go. And I had a wildly different experience because the first time I didn't know it until afterwards. I'd actually ruptured during the procedure and was in incredible pain while they were doing the procedure. And I
Yeah.
kept getting more medication. But then when I did the RFA with you, it was like there was no pain at all.
Yeah, and that's typical. I would have to say there are, obviously a variable responses to an RFA, but most patients, this is very well tolerated procedure. Is occasionally a little twinge here and there, some discomfort. This should not be an extremely painful procedure. That's atypical, and that might raise some red flags. In fact, one of the reasons that we keep you awake for the procedure is so we can monitor your pain level to make sure that everything's going okay, to make sure that there isn't some issue or we're getting close to critical structures, because pain is a red flag that maybe we got to rethink our approach.
Yeah, yeah. So the procedure, as far as you were concerned and as far as I was concerned, it felt like it went well. Like I didn't have any concerns. Would you say that there were any initial concerns after that procedure?
No, no, I mean, I think we were still concerned. Your case is extremely unusual. Your first case is extremely unusual because rupturing on the table during the ablation, I don't know that I've ever heard of that except in your case.
Mm.
Most of the time, there's sort of a delayed response, a week, days, sometimes even months afterwards. And so I was happy the procedure went well, but I really think you're not out of the woods until a little bit of time has passed when it comes to that complication of rupture.
Okay. Yeah. So everything was looking good. We waited a few weeks and I think we were scheduled to do another RFA maybe 3 or 4 weeks later. I wound up getting sick, and so we wound up postponing it, I think, a couple more weeks. And then you were at a medical conference, I believe, and I wound up having pain in my neck, and I was starting to experience some of the old symptoms. And then I remember reaching out to your office and being like, I think that it's opening again. So
Yeah.
and then I think I had texted you some pictures of what was going on. And so I just want to hear from your perspective as a physician who took on this complicated case to begin with. And you're at a medical conference, you're not at your office where you can see me in person and address the situation.
Yeah.
What are your thoughts, receiving that news?
I don't know how much we want to go into the experience of a physician who experiences a complication or a repeat complication. Yeah, it's devastating. It's the worst thing we do in medicine. It's very hard, and of course, it's the patient that's going through it, but we go through it with the patient. So the last thing you want to see, all of a sudden, you know. Anyway, it's very very difficult to have these types of things, and it's unfortunately part of what we do.
Yeah. And I think that it's really important to go into that. I don't think a lot of people talk about, you're a medical professional and this is your job, but you're also a human being who is a very caring human being who's really good at what you do. And you take this oath, to take care of your patients. And I think it's important to address how it impacts you as a person too, to have, to go through this experience. So I appreciate you sharing, what it was like for you.
Well, I appreciate that. Yeah, I think it's something that we don't talk about with amongst one another, but anybody that does a procedure, does a surgery, is involved in these interventions, or you're going to run into this sooner or later. And you're right; it's something we should be more forthcoming about
Yeah.
discussing.
And I also think, just as a little side tangent, the more we talk about it and the less stigma there is, and the more that doctors are accepting of, I mean, these complications happen. It was no fault of your own. It's just what happened, right? And I think what I've noticed working with more rupture patients over the years is I think that there's a lot of patients that are going undiagnosed
Yeah,
because maybe the doctors are feeling some sort of way about it and struggling with that internally. And I definitely think that that was a component of why it took me so long to get diagnosed the first time, is that I think doctors don't want to know that this is happening, or to go through that process and face that something has gone wrong, so to speak, in some situations. So I think it's really important for us to um, help address the stigma around it and just, acknowledge this is totally normal and it's okay if a physician is having a difficult time with it. And I think that facing it from that human perspective can really be helpful in quicker diagnosis and really facing it. And then also, the compassionate care towards the physician as well, and for us to work together as a team. So I just really appreciate you, sharing that about your journey.
Uh, Thank you. I know I agree, and I think something happens when you start in medicine and you get a complication and you're early in your career. It becomes a moment of real self critique and self doubt. And then time moves along and you realize that this is something that just happens, and so the experience changes a little bit. It's still really hard and still devastating in a lot of ways, but it becomes less about this crisis of self and more about just now we know this happens. It happens with some regularity. This is not necessarily something that's been done wrong, but then it allows us to address it head on, to treat the patients earlier, to recognize these complications earlier, to not be afraid to declare a complication and to not postpone its treatment. Because I think, especially in the case of thyroid nodule rupture, but everything, addressing it early on affects the ultimate course of these things. So
Absolutely. So, what would you say to another physician who's going through this if they stumble across this video and it's because they think that their patient may have ruptured and they're feeling
yeah.
some sort of way about it? Is there any advice you would give to them?
Well, the first thing, and this is true of any complication, but if we're talking specifically about thyroid nodule rupture, the patient contacts you with a concern or voices a concern. You really got to take that concern seriously. There's really sort of a tendency, as you're saying, just to hope this isn't nothing and to wish it away. And sometimes that's true. Sometimes patients get aches and pains, and it's not something. It's not a rupture. It's something else. But to really take that seriously from the get-go, out of the gates, is number one. Number two, this is honestly just not a complication that's well known about. It's better known now, but 5 years ago, because it's so uncommon, it's just not something that people have encountered. And so, specifically for thyroid nodule rupture, a patient does fine, is okay, and several days later, a week later, things suddenly get worse. That's a red flag that this is a rupture, and immediately I would take the patient in and do an ultrasound because we can scan and see that there is in fact a rupture. Just not to wait. Again, the clock is in some ways ticking. If you can address that complication earlier rather than later, you might prevent this making its way to the skin opening, this what we call thyroid cutaneous fistulization, and mitigate the effects of the rupture.
Yeah, and I'm so appreciative that you said that because I think from a patient perspective, the fact that you took it so seriously and you paid attention to literally every single one of my concerns over the past couple of years, and I really felt heard and understood through the process. Actually, going through the re-rupture with you was healing. It actually was the opposite. I think having that traumatic experience I had before and not having answers or maybe the attention that I thought would have really supported me, having you then listen to me, it took something that could have been super, super fearful all the way down. So you reduced my fear considerably by the fact that you were so attentive, that you were listening to it, and that I knew that if I had a concern, I had somebody that would walk through that process with me and would take my concerns seriously, which was so greatly appreciated. I literally can't thank you enough for that. So I'm really glad that you brought that up. And that kind of like leads into the next thing, which is that, you're away at this conference and I'm showing you these pictures of literally tissue starting to come out of my neck again. And I start to suggest to you that maybe we should strangulate it. And I don't think that you had ever done this before, ever heard of this, but it's something that I had done with my prior physician that actually my wound care nurse had suggested when we were bumping up against walls, didn't have any answers. She was like, would you want to ask your doctor to, tie something around it? and strangulate it. And we wound up trying it and it worked. So then when I was facing this with you and you were away, my mind went immediately to, okay, this is a great next course of action. And so I'm presenting you with this
Yeah.
idea. And what did that feel like for you to have this option on the table and a pretty persistent patient saying she wanted you to do this thing you
Yeah, well, yeah, this was a new process for me, and I'm really glad to learn these things. I learned a lot, over the years with your case specifically. I guess the first question is, am I going to do something that might hurt the patient? And that's the first consideration. And then, of course, you read it about a little bit, and there's no cases in the context of thyroid nodule rupture, but you read about it in other contexts. And then you sort of slowly gain confidence. And then again, really a lot of it is understanding that you have a partner in the patient that, very forthcoming conversations about how, okay, I've never done this before, but I'll read about it. I'll do my best. And you understand that this is sort of uncharted territory. We'll do it together. So, yeah.
Perfect. So if another physician is in this position and they, watch this and there's this patient who has tissue hanging out of their neck, we have no way to address it, and they're like, maybe this might be, something that we could try. Could you then walk us through what you did in this procedure? How did you strangulate the tissue coming out of my neck?
Sure, I'll try. So it's actually kind of a very basic procedure. Make sure that you do it sterilely. I think the first thing to understand is what is coming out. It's not clear necessarily what this tissue is, but looking at the imaging, making sure there's not protruding big blood vessels or something like that is probably the first step. And then essentially what we do is we take a suture, a string, a sterile string, and we wrap it around the base as low as we can go, and you just tie it off tightly, and eventually it just sort of sloughs off and falls off. Yeah, simple as that.
Okay. So, and one of the other things I want to mention too is that the first time I had had it done with like a I'm sorry, a strangulation kit, which is almost more like a wire. And
Yeah,
at that particular hospital, like that's not a common practice. It's
right.
so we used instead, you used, is it the suture string?
Yeah, just a suture string, which is what you would, if you got stitches, that's what you would get. So it doesn't have the rigidity of a wire per se, but it still, did the job, and it's what we had available.
Yeah, yeah. And then so you tied it off. And one of the things that I could do as a patient too is I could continue to tighten it. And later on, like as some of the tissue would die, I would tighten it a little bit more and it would cut off more of the blood flow until it eventually just fell off. And one of the things that you did also was you had used silver nitrate. And that was the first time that we had tried silver nitrate. It was kind of like the beginning of this experiment that worked out really well and became another, method that we used throughout my process. So, what was your thinking in bringing in silver nitrate?
Well, I've used it in different settings. So, silver nitrate is basically a chemical cauterant. It's like cauterizes tissue via chemical reaction. It has some like antimicrobial um, effects as well, and we use it in cases where we sometimes see exuberant granulation tissue. So granulation tissue is sort of your body's healing response at a wound, and sometimes that becomes so overflowing that we want to get rid of it. So I've used it in other contexts, and that's part of what was going on at the wound was granulation tissue and your body's healing response in addition to just thyroid tissue and oozing stuff coming out of the neck. So again, didn't think we could hurt it, and maybe this would help, and maybe it would help to regress some of that tissue, and I think it did. I think it probably helped and shortened maybe the course of the wound a little bit. I don't know how much. Probably nature would have taken its course and would have healed on its own, but this probably sped it up a little bit.
Yeah, I would say so. And especially, because I had the experience of being able to compare the first time that I had ruptured and the other experience to this, one of the things that I witnessed was that I had the very first time quite a large nub of tissue hanging out. It was almost like a square inch hanging
Yeah.
out of my neck for, I want to say about 5 months until we decided to strangulate it. And we kept thinking, oh, it's going to heal, it's going to, take care of itself. And it just really wasn't. It wasn't making any progress. So that tissue actually had to be removed in order to give room for the skin to close over and more draining to happen. So it didn't actually close until there was no more skin protruding. So I think that that was also one of the reasons that I could tell immediately, like, wow, this is helping, this is working, we're going in the right direction. Because as long as there's skin or there's tissue protruding, the skin couldn't quite grow over it. So,
Yeah, I think that's true. And I think this is one, maybe taking a moment to say how unique your case is. And I don't, I, I think with thyroid nodule rupture, less is more. The less we know over time. It used to be we see these things, we were very nervous. We would do all sorts of aspirations and things and interventions. And as time goes on and as we understand more about this complication, we tend to be hands off. These are sterile collections, they're not infected. They tend to just heal on their own. Your case is unique in that you had such a large thyroid nodule to begin with that there was so much fuel feeding this wound. And so I think the threshold to try to treat some of this tissue was less because we had to speed this process along or it would have happened over months and months and months and months. Patients with smaller nodules which are more typically volumed are going to have less fuel. Eventually it's going to exhaust itself and maybe we don't have to be as aggressive about those types of interventions like strangulation and silver nitrate and all that stuff. So
sure.
I don't know that all of these things we did with you are applicable across the board, but I do think it worked in your case in our favor.
Yeah, that's a good point. Is that maybe I'll overlay a picture of just how big it is when I edit. But I
Yeah.
mean, my goiter was quite sizable, and so there was so much pressure pushing on it, and this tissue had nowhere to go, and so it was coming out. It was very different than how my neck looks now. So yeah, every case will be different, and that just happened to be how mine was. So were there any risks that you were considering as you embarked on this journey of doing a strangulation procedure? Was there anything in particular that you were taking into consideration? I remember you ultrasounding it and wanting to look for any like blood vessels. Is that right? Or what were you considering? Any other factors?
Yeah, again, yeah, I mean, we have a complication. We want to make sure that we don't make things worse. I think the one thing we'd always think about is could this infection, I mean, could this process, which is sterile at this moment, could we infect it by fiddling with it, by introducing bacteria from the skin? So that's probably the first thing is making sure that we're not doing anything to imperil you. So again, kind of less is more often is the case with nodule rupture, but in your case, there's so much expression of tissue that I think we need to help things along. Ultrasounding, just to make sure that the tissue that we're strangulating doesn't have big vessels coming through it, that we're not going to injure a big blood vessel. I mean, small vessels for sure are there, but not anything we don't intend to do. Those are some of the considerations.
Okay. So walking through the timeline again. So then I go home that day, and I believe by that evening it had fallen off, and I had sent you a picture, like it worked. And so then I had done some more research, and I was essentially just Googling, and I didn't know about silver nitrate until, we had had this conversation. I was looking it up, and I found a wound care article that was suggesting doing repetitive silver nitrate treatments on some forms of open wounds. And I threw that by you and suggested that, and then we wound up trying that out. And so, can you walk us through that next phase, maybe the couple weeks right after we did the strangulation and what we started doing?
You might have to help me.
Okay.
I remember doing
Okay.
many silver nitrates, week after week after week for a very long time.
Yeah.
I think we just fell into a rhythm where we felt like this was helping. Felt like we were treating the expressed tissue and it was regressing. And then later we got, a wound care specialist, and because we are somewhat far apart, we were alternating that and making sure that you got treated on a regular basis between the two of us. And we worked really well together. I learned a lot of stuff from your wound care specialist, through you. Um, so I think we just got into a rhythm where we just chipped away at it and knew that eventually we would get there, or hoped eventually we would get there, and just let's continue to slowly treat this. And try to have a good attitude about the conclusion, which had to have happened at some point, and it did eventually.
Yeah. Yes, it did. If I remember correctly, it was those first couple of weeks we were doing it quite frequently. It was maybe every other day. And then we eventually got into a rhythm where we were doing it maybe 2 or 3 times a week and we were alternating. I think I was seeing you on Fridays and I would see Dr. Corey early in the week. And then
Yeah.
sometimes we would even do it myself. And essentially what we would do is we would put some either calmoseptine or like a Vaseline or something around the perimeter because if the silver nitrate, once it turns into like liquid, it will drip down and kind of burn your skin in other places. So we kind of surrounded it, and then you would do the silver nitrate. We also learned along the process from the wound care physician that we could put cream Novocaine on it, so it was less painful. So we learned a lot, and I started putting Novocaine on it before I would go in for the silver nitrates. You would do it, and you would target that area, and we would really essentially kill the tissue that was starting to protrude. And it would also make it more comfortable for me as a patient because the tissue that's protruding has nerves. And so it's rubbing up against the band-aid or the
Right.
bandage that was on it. And so every time we did the silver nitrates, I was also feeling more comfortable. It was painful for a moment, but then in the end, it was a lot more comfortable for me. It was more comfortable for bandage changes, and it felt like we were moving in the right direction. So I think maybe a month or two go by where we're doing these silver nitrates. And at that point, I think you had already told me that RFA was off the table moving forward and just
Yeah.
needed to heal. And I understood, but was understandably a little bit bummed. And then as we were continuing to do this and time was going on, it was like, okay, well, what are the other options? What else could we do? And I think at that point, I had reapproached you with the option of doing an embolization because initially that was one of your suggestions. And in retrospect, I should have listened to you and done the embolism first and then done RFAs. So, can you walk me through the logic behind that?
Yeah, sure. Embolization is, RFA is relatively new in the United States and in the thyroid gland, and embolization is newer and has a little bit less of a track record. But embolization, the way it works, is by disrupting the blood supply and shrinking this nodule out of the gates. And I guess theoretically, presumably, the inflammatory response that we were talking about that comes with RFA doesn't necessarily come with embolization because you're actually decreasing the amount of fuel into this thing. So we did on the very first visit, we talked about embolization versus RFA, and frankly, I don't know what the better way to go is. Certainly in retrospect, we could talk about which way we would change things if we would change things. But embolization was always a very interesting option to me. It's great for patients that have very large nodules that are maybe difficult to address with ablation, or we know it's going to be multiple ablation sessions. Um, so yeah, fortunately, I have a colleague at UCLA that does these, and we talked extensively about your case. Again, everybody treads cautiously, and somebody that's already had not one but two complications at this point. Um, uh, but we talked through it, and we talked through it with you, and thought that might be a good place to go.
Yeah. So one of the thoughts behind that is, at first we were hesitant to do it because I had already ruptured and nobody had ever done any, at least that we knew of, nobody had ever done an embolization with an open wound of a ruptured thyroid. And one of the things that I had talked through with the wound care physician, Dr. Corey, at this time, was that part of the reason that the tissue was protruding is there was just so much pressure. And so what happens, this was the theory, right, is that the nodule was so large, there was so much pressure that when the inflammation occurred after the initial RFA, there was swelling, and that swelling was possibly what opened up that old wound. It was like that initial tear that had healed over from the first rupture, wound up with the pressure of the swelling, and because it was already so big, pushing on the capsule already, had reopened it. So when I had ruptured with you, it was not really a traditional rupture. It was like a reopening of an initial rupture where there was a wound
Right.
almost like pre-existing there that got opened back up. Is that
Yeah.
right?
Yeah, I think that's true. I like that better actually. It's not another rupture, somebody else's rupture that just happened to come back. Yeah, but I think that's true, and based also in the fact that the location of the rupture at the skin was a little bit different, but if you look at the thyroid capsule, it was essentially the same injury, that same initial injury that just sort of had reopened.
Correct. Yeah, because it was in the exact same spot, right? And it was the same thing that had happened. So I also want to just highlight too that none of these decisions were made overnight. I think originally we had talked about this and I had asked, and it was like, no, this is not an option. This is not a good idea. Let's
Yeah,
just wait and see, let's let it heal on its own. And then I think another month or so went by, and then I had talked with Dr. Corey, the wound care physician, and he had at that point said, actually, I think that this is a good idea because it will reduce the size of the nodule, which will reduce the pressure that's on the
yeah,
wound. And I think it will actually help the wound heal. And so
right.
it was after the discussion with him that I had then reapproached it with you, and then you reapproached it with Dr. Say. It was like it was this process of all of us sitting with it, thinking about it, weighing out pros and cons. It was really a multidisciplinary approach, I feel like, in order to get to that conclusion. So it wasn't really a clear path of we do this and then we do this. It was like there was a pause at every moment where we were sitting with it, thinking about it. What are the options? We would talk back and forth at our silver nitrate appointments, weighing out the pros and cons until we finally got to that point where Dr. Say felt comfortable with doing it and we felt like it was a good option.
That's right. That's right.
Yeah.
And so much of medicine is based on experience. I mean, we know what we do because they're the people that taught us how to do this, did it this way. And so we're in a territory where nobody's done anything. So we're sort of, making the rules as we go along and learning a lot as we do.
Yeah. And I think it was that constructive approach and collaborative approach that really helped us to get to the excellent outcomes that I believe we reached. So thank you. So, okay, so we go to the first embolism that I did. What were your thoughts or risks related to that?
Well, again, we're in sort of unknown territory. I think the theory that we're going to reduce the blood, the inflammatory response, just all the activity that's going on in that thyroid gland that's fueling this ongoing wound and fistula. Um, that's what we're hoping for. But at the same time, you have a wound, and we know that we need blood and all the reparative mechanisms that are carried in the blood to help this heal. So it's a balance between trying to reduce the inflammatory response, but at the same time, not trying to compromise the healing response. I guess that's our concern. Are we going to make the wound worse by reducing the blood supply to that area? Um,
Yeah. And it actually wound up working out like in our benefit. I was tracking the wound changes, so I would change the silicone bandage a couple times a day. So I was
yeah,
tracking how much drainage it was, taking pictures of the bandages, and we were able to. I think it reduced maybe 30 or 40% of the drainage that was coming out after that first embolism. And I just want to. I have some notes here. I just want to highlight. I think that in the beginning, before I had had any treatment, my goiter was like over 500 cc's. It was huge. And then
yeah,
after that first RFA where I had ruptured, right before the first RFA with you was 447. So that's prior to UCLA, it was at 447. And then 4 weeks after the first embolism, it was at 355. So it had gone down nearly 100 from the first RFA that you and I had done together and that first initial embolism. So it was like, okay, we're making progress. I had an open wound on my neck, but we were still able to move forward with the treatments and I was getting results, which was really exciting. And so we had done that embolism, and then you and I start talking again. It's like, okay, we did this and it worked. What else could we do? And I think that's, I forget exactly how it happened, but I think had asked maybe about the NSPFA as an option again.
mhm,
Initially, I didn't fit into the criteria, and then something had evolved and you had asked for their special permission for that. And then we wound up doing an NSPFA. So can you kind of walk me through how you were able to then get comfortable with doing an NSPFA on my neck after that embolism?
yeah. It's an SPFA or pulse field electric ablations in general are a really interesting, much newer ablative technology where instead of using heat or cold based, what we call thermal ablation techniques, we're using high voltage, short electrical bursts. And what those do is those destroy the cells, but they don't do it by, this sort of burning, this heating of them. They do it in a more controlled fashion. That electrical activity disrupts the internal stuff, the organelles, and then the cells sort of die a nice, quiet, non-inflammatory death. And so theoretically, the theory is that that mechanism of cell death does not evoke the same inflammatory response that a thermal-based technique would introduce. And so that was the theory, that here we could maybe get good volume reduction, but with less of a risk of inflammation and re-rupture. Um, and this is a new technique, and we did work very closely with the vendor and talked about your case specifically, and they're trying to control the types of patients that they're applying their technology on in the beginning, which is appropriate. And your nodule was much bigger than sort of what they had in mind, but at some point we talked about it, and they thought, okay, sure, let's give it a try.
Okay. So, can you walk me through then from your perspective, again, as a physician who has this complicated case and you're deciding to do NSPFA with me, and it's also your very first NSPFA experience. So, walk me through just like the nerves, how you were feeling going into that procedure. How was that for you?
So for the procedural part of it, the placement of the needle and the application of the energy is very similar to RFA. So I didn't have much in the way of discomfort in terms of learning a new technique. It's really, from my point of view, a very similar technique. What's different, I think, is the sensation of the patient. With RFA, um, you get the thyroid numb with local anesthetic, and that usually controls things predictably. With NSPFA, it's a little less predictable in the sense that that electrical energy also stimulates nerves, and it does so in a somewhat unpredictable fashion. So some patients have twitching or coughing sensation, and it's a different sensation. It's a sensation that, as a doctor, we're not used to, imposing on patients, and patients aren't used to feeling, because it's an electrical type energy that's atypical. It's not something that we experience very often. So the procedural part of it very similar, but the patient response is a little bit different. And it took you a moment to sort of see what this is, and me a moment to see sort of your response to it and how we're going to manage it, and how far we have to stay away from structures to avoid stimulating them, and things of that nature. So procedurally, kind of a very different, or from the patient point of view, I think a very different experience.
Yeah, yeah. And so if I remember correctly, I did a bunch of research as well. So you and I were both doing research, knowing that the first one we
Yeah.
would both embark on together. And so I was looking at other patients through Jen's Facebook group who had gone through NSPFA. I was asking questions, and you had asked some colleagues as well. And we decided to try it out. Well, it was more my decision, and you kind of went with it. I want to
Yeah.
but I was curious. I wanted to feel what this was like, and I think because it was a newer technology, and most people were being sedated to a degree or receiving some pain medications. I wound up doing the first half of it without that, so I could just feel exactly what this felt like. And then the second half of that first one, we did give me some, was it Versed? I don't remember what the cocktail.
Yeah, a little bit of Versed and a little bit of fentanyl, I think. That's what we usually
Yeah.
use.
Okay. So I was able to experience the pulses, which were, I mean, it's like a pulse running through your body. But I think for me, because I was so prepared, I had done so much research, I had no problem with it. And I was also just so excited that you were willing to continue.
Yeah.
And that I could have this experience going through it both ways, that I was hoping to then also be able to help other patients with being able to compare the different experiences, because there are some people that can't take those medications and they wanted to be prepared for what it would be like. So I
Yeah.
would say that it was definitely more comfortable with the Versed and fentanyl, but it wasn't undoable without them. I just needed the preparation for it, like just getting myself mentally prepared that that's what it was going to be like and that's what we were going to do. So The first procedure, I'd say, went really well. I was still swollen afterwards, similar to the RFA, and I don't remember if it was that one. I think it was the first one. I had some bruising on my neck as well, which we later discovered was somewhat common for NSPFA procedures. But overall, it went great, and my neck continued shrinking. So it shrunk quite a bit over the next month, and then we decided to do it again. So, what was that like for you, coming to the conclusion that, hey, this worked, and let's try it again? How did that feel for you?
That felt good. I mean, we had one under our belts, and it went pretty good. And so, and you still had, just for reference, 20 cc's. 20 cc is a big nodule. You had a 500 cc nodule to begin with. There's plenty of tissue that we still got to go.
Yeah.
We're still chipping away at this tissue, and so yes, I was open to trying it again for sure, because you certainly were.
Yeah, yeah. So we had done the first NSPFA, I want to say in November of 2024, the second one in December of 2024, and then after that second NSPFA in January, late January, I measured at 179 milliliters. So it had gone down considerably after all of those procedures. So then at that point, we kind of regrouped and we're like, okay, we had done this a couple of times, and I also had I want to say it was like a 6 month follow up with Dr. Say, who had done the embolization. And at that time, I then approached him and asked if he would be willing to do another embolism, which is something that he had kind of talked about the first time that that was an option. And it was still large enough at that point that it sounded like a good idea. So then we wound up doing that. And how did you feel about me doing a second embolism then?
Yeah, it's a good question. So embolization, usually you're disrupting the blood supply, and but sometimes there are other blood vessels that are feeding the goiter, or there are reestablishment of the previously embolized
Mm.
vessels. So I believe he did a CAT scan to see how the vessels, and he thought there were still reasonable targets, and so I thought it was a very reasonable thing to do, and we had good success with the first one. And again, we got plenty of goiter to go, so let's keep going.
Awesome. Yes. So it went down even further. And in just a month after that second embolization, it went from 179 to 146. So it was still decreasing. We were getting really good results. And, I actually should have just backtracking a little bit, should have mentioned that it wound up closing a little bit after I want to say the first pulse, and then my neck opened up again after the second pulse. And so while all of this was going on with you at UCLA, I was still seeing the wound care doctor on a regular basis. And we were also doing cultures, and we had done lab tests at different
Yeah.
times. And then there were a couple times that cultures came back questionable. I wound up also getting an infectious disease doctor involved who looked at the lab work. And so while we were doing these treatments and we were also cutting off the blood flow, there was a concern that if I did get an infection within the thyroid capsule, that it might have less blood flow to help it to uh, cure an infection, and that if I did get an infection, it might be more risky. And so I just want to mention also, we just had this very multidisciplinary approach, making with lots of checks and balances, like making sure that we were looking after my well-being throughout the whole process. And I think somewhere in there, I did wind up feeling some discomfort in my neck and did get an infection. I was on antibiotics for a little while, and so throughout this whole process, whenever something looked off, you were always incredibly responsive as well with ordering lab tests for me so that we could check the sed rate and the procalcitonin and these different things to make sure that we were addressing it, making sure that I didn't have an infection too. So how did that feel for you to have all of these people in the mix and to be ordering these labs that are not typical things for you to be involved with, maybe?
Well, very much a relief to have people that are experts in this area that are weighing in, for sure. You know, I, part of modern medicine is we become very subspecialized. We know our area very well, but it's hard to know all areas very well. And so, very happy to have infectious disease on board. Very happy to have wound care on board. Very happy to have um, Dr. Say and Angio IR on board. So it's having more people, I think, just brings more information to the table, more expertise to the table, makes you feel like you're serving the patient in a better way.
Yeah. Do you think that that was a key factor in any way with you agreeing to continue moving forward? Because, from my perspective as a patient, there was part of me that was like, I, he can say no. Like, he can say
Yeah,
no and not
yeah,
continue treatment if you felt that it was too risky or something, could happen with it. And so, do you feel like me, bringing in these different people and you also, the collaborative component of it was something that helped you feel comfortable moving forward? Because I know that sometimes physicians get to a point where they just say, no, we're not going to move forward. So what helped you feel comfortable continuing to pursue treatment with me?
yeah. Two things. One is that collaborative nature, especially like the alternative from the get-go before we started any of this, before you had your first RFA at this outside place, was surgery. And probably, many people would say, that would might have been a better option at the time. And but having after that rupture, having surgeons on board that are not saying definitively we want to go to the OR, and having that multidisciplinary discussion is critical. And it's just how, again, I'm in an academic center. This is how we operate. We always operate talking to one another and coming together as a group. So yes, very important. And the second thing is, it all comes back to you as a patient. You're a thyroid interventional explorer. You really were open to, even eager to find new ways to treat this. You were interested in pushing the envelope. Every discussion we had was thoughtful and measured, and I felt very confident that you understood the risks and that we were in territory that we were exploring together.
Yeah.
Um, and so, yeah,
Yeah. You know, I think another piece to mention too about the team is the surgeon, like you had mentioned, is that the surgeons were actually for this. So
yeah,
while this was going on before, the doctor that had actually referred me to you said one of the criteria in him agreeing to do RFA with me is that I needed to meet with another surgeon because I had some bad experience with surgeons that I consulted with in the past, but they had a phenomenal surgeon that I met at UCLA, and he was just amazing throughout the whole process. And so I had him as a backup at all times. And I kept going back for follow-up visits with him, considering that as an option, weighing everything out. And at one point, I had communicated with him, look, I've done these embolizations. There is a concern of a risk of infection. We're talking about this at length. What would we do if there was an infection and I had to have an emergency surgery? Could you still be my surgeon? Because I finally felt comfortable with this surgeon. I wanted him to be able to do it. And he was like, no, let me give you my cell phone number. If you ever get an infection, let them aspirate it at UCLA, like do whatever needs to be done interventionally, but then give me a call and we'll schedule you like within 24 hours and I will be your surgeon. We will take care of this. And he's like, and I will then coordinate with the plastic surgeon because at that time it was so large that it was a team of the surgeon that would remove the thyroid, and then the plastic surgeon would have closed it up at that point when we were considering that option. So that also gave me great peace of mind as well, knowing that if something should go wrong, we had backup plans.
yeah. For me too. In fact, I think a criteria for me, a discussion with a surgeon and a surgeon that's weighed in, and as part of this multidisciplinary team. I think without that, we would have been having different discussions.
Yeah, yeah. So thank you. It was very helpful. And I'm glad we didn't need to use him, but it was also great to have his input throughout the way. And there was something really beautiful about just having a surgeon be like, wow, this is amazing. Because, as you said, most physicians, like you get very specialized in your niche. And so he was very specialized in surgeon. And so I think he was also really excited to see like, wow, there are other ways that this could be done. And I really like this other way. This is working for you. Keep doing what you were doing. And so so I think I also had a team of doctors that were all looking at what was best for me, what I wanted. And because everybody was coming at it from that approach, it just allowed the process to keep moving forward. Um, so then going to back to the timeline. So we did the second embolism, and there was still some more tissue to treat. It was still large, and so then we wound up revisiting and doing a third NSPFA or pulse procedure. And so, how was that for you at that point? I think you had. Correct me if I'm wrong. At that point, you had also done other pulses with other patients. Is that correct?
Yeah, correct.
Mm-hmm.
That's true.
So,
How was the third one? I don't know that I specifically recall.
okay.
Um, you tell me. I don't know. How was the third one?
The third was a little rougher. So by
A harder one. I do remember when you woke up from anesthesia. You were having. First, we did it with general anesthesia,
mhm.
which was a new process for us. Is that true?
That was the third one we did with general anesthesia. So
General anesthesia.
I was out, yeah.
Yeah, right.
And you were able to use the higher setting on the pulse machine or the normal
Yeah,
setting. I think there's like a low and a
normal. Yeah,
normal. Yeah.
default.
But the
Yeah,
normal is the
that's
high
right.
one.
Yeah.
So when you were able to use that one, and I was out for the procedure, so I don't remember it at all. But I remember when I woke up, I was in tears. Like it was really painful, and which is fine. I'm not complaining. I'm so grateful for it. It was, I knew all of these risks going into it. I wouldn't take it back. But how was that for you, having a patient, wake up in tears and just obviously in a lot of pain? And it took us a little while to get the pain under control too.
Yeah, I do remember now. Yeah, a little unusual and unexpected. And still, I don't have a real reason for it. I mean, yes, with you under general anesthesia, we were able to be perhaps a little bit more aggressive in terms of the amount of energy we're using, but not that different from the other two. And why the post-procedural course was so much different in that case, I still don't have a good explanation
Mm.
for it. But very atypical for a patient to wake up with so much discomfort. Uh, and yeah, troubling for you, I know, and certainly troubling for me as well.
Yeah. But we got through it and it was totally fine. It was totally worth it. We got the pain under control. But what we realized, for me at least, and every patient again is different, is that with the NSPFA, for whatever reason, I wound up being in a lot more pain later on in the day. And so I wound up taking like a Percocet that afternoon and evening after the treatment. But then after that, I was totally fine. Whereas the RFA, I didn't have that experience. I didn't have that degree of pain, which was
Yeah.
an interesting comparison and just something that I learned. I don't think it's right or wrong or bad or whatnot, but that was something we kind of learned how I was reacting to each one of the treatments too, and how we could kind of mitigate things. And then also another thing is that I had had a really bad experience with steroids many years ago, and so I was hesitant to try steroids as a precautionary tool, but then I wound up trying it with the second embolism with Dr. Say, and I was fine with it. Like the low dose temporary steroid was very different than my bad reaction that I had had maybe 20 years ago. And so we wound up doing that with I'm skipping ahead a little bit, but we wound up doing RFA again. We did
Right.
that and I responded really well. So that was also another kind of tool that we had learned and tweaked. So, okay, so going after the third NSPFA, we waited a little bit longer then, and it kept shrinking. I was doing really good, but there was still some room for it to be treated, and it had been closed then for quite some time. So it had healed over. It had been closed. I want to say for at least 6 months. I'd have to go back and look at the timeline. But after it had been closed for quite a while, I remember in one of our follow-up appointments, revisiting with you and saying, "What would you say about revisiting RFA? I know we had originally taken it off the table, but part of the reason that we had taken it off the table is because it, caused that inflammatory response, pushed on the original opening wound and had caused the opening. But now that it was so much smaller, is that really the same type of risk that it was before?" And so, can you kind of walk me through your thoughts on what got you to say yes to doing RFA again after my FUS 2 resulted in my neck
Yeah.
opening?
Well, some of it has to be just the amount of time that had passed and, the trauma easing over time and you sort of forget, what a process it was. But part of it was that rationale also that we're not talking about a 400 or 500 cc nodule anymore and that has all that fuel and juice ready to try to be expressed out of a wound. Now we're talking about a much smaller nodule that's much more typical of the nodules I treat with RFA. And in fact, I think the residual tissue is a little bit distanced from the wound, from the so-called necrotic ball that had been fueling that. And so I think the thinking was that we would probably just have a much less aggressive ablation. The wound's been closed for some time, so presumably the capsule has healed over. And again, we had a long discussion, and you were interested, eager to try it, even understanding that that was a risk. It was a risk that had happened and it might happen again.
Yeah, yeah. So, so just to give a little bit more of an idea of the how much it had shrunk. So in October 15th of last year, 2025, it was measuring at 76 milliliters. So that was before we did the RFA. In January of this year, January 2026, and then April, just a few months ago, we measured it at 38 milliliters. So I remember before we did the RFA, it was like, it's already shrunken so much. We had treated most of the area. Like, is it even going to shrink anymore? And it wound up shrinking in half
Yeah.
between early this year and April. So I like the results were just phenomenal. And I think overall, through all of the treatments that I had at UCLA, just at UCLA, not even the treatment before, it went down 91%. Like that's incredible. So my goiter to shrink 91% over the course of a couple of years and all of these different treatments, I think are exceptional results. I don't think that we could have ever imagined that we would have that good of results in the very get-go. But I think the approach of just taking it one step at a time and seeing where we were and continuing to communicate, collaborating with a greater team and just your patience and willingness to stick with me through this. I think we got phenomenal results. So I am so grateful for it. I want to hear, your reaction. Did you think that this was possible, and how do you feel after this long journey that we've been on together?
So no, I didn't think we would achieve that degree of volume reduction ratio, to be frank. I think you did phenomenal, and it's the best case scenario. Sometimes when we talk, often when we talk, I go back to before even your very first ablation, before that first rupture, and I ask you the question, and maybe it's best for you, knowing what you know now, and I know a lot of people come to see me because they're trying to avoid surgery. Um, and and sometimes that's my goal, to avoid surgery, and sometimes I think surgery is the appropriate thing to do. So knowing what we know now, I always ask, would surgery from the get-go be something that you would have chosen if you could go back in time? I mean, I think you did great. I think you continue to do great, but it's doing great after two thyroid artery embolizations, three RFAs, three NSPFAs. It took and countless silver nitrates. It took us a while to get here.
Yeah,
It's been a
yeah.
long, hard course for you, and so I don't want to. I think you did phenomenal, but it took some work to get there too, and not to minimize, all these procedures and all this, at times frank trauma that you went through to get here. I think about that often.
Yeah. So to answer your question, if I could go back and if I had a crystal ball and I could go back to 2014 when the option was just easily to do a partial, like just take out the left side of the thyroid,
Yeah.
if I would have known the type of journey that I was going to be on, I think I would have considered just taking out half of the thyroid back then. However, if I could, knowing everything that I know now, go back with a crystal ball and was starting over in 2022 when before I had my first treatment, hands down, I would have just come directly to you and probably done the TAE with Dr. Say first before any RFA,
Yeah.
and then continued with RFA and NSPFA with you. And if I could weigh out the options, that by far would have been it. So part of the reason that I'm, passionate about sharing this information is that I had a really large goiter for about a decade and it just kept growing and I tried so many different things, but I never found RFA. Like I had a lot of doctors. I brought in a lot of different people to help me with this, but I didn't know that it existed until I stumbled across Jen's information. And so I think that there's just a huge gap in understanding what the real options are for patients. And I had also had some physicians that, frankly, I just didn't trust being under, or that they were going to do what I wanted them to do, and that we were really
Yeah,
collaborating truly. And so, having that experience, it really turned me off from some of the other options. So ultimately, like best case scenario would have been back in 2014, being able to do RFA back then. Like that would have been much better before it had grown to the state that it was. I would have loved to have had that option. Then I could have taken surgery off the table
yeah,
entirely. But I still think that for me personally, I'm grateful that we did it the way that we did. I think that there were things that could have been done, I think, to avoid the rupture, though. I think understanding the thyroid capsule the way that I do now, my recommendation for, or my thoughts around this, if I could do it over again, would be to do the embolism first to
yeah,
help the thyroid capsule reduce as much as possible, and then go in with the RFA, because I think that the reason that I had ruptured or and then re-ruptured is just the swelling,
yeah,
putting the pressure on it. And that was, just me being in my body and feeling the sensations that were happening in my neck too, feeling the swelling, feeling the pain right there, like as it was pushing and getting bigger. I really think that it was related to that. So yeah, those would be my thoughts. And if I could, do it all over again, those would be the tweaks that I would have made. But I'm really grateful for my journey. And I feel like I learned so much. And I'm so grateful that I was able to learn all of this and go through it with, I think going through it this second time with you helped heal me. Like it was actually, from your perspective, it might have been a little bit more traumatic for you experiencing a rupture with a patient. But for me, I think it's so different to go through a medical complication and feel not supported versus going through a medical complication and feeling listened to, supported, having resources and tools, and being able to navigate through it in a way that is healthy and supportive. And so that to me made a world of difference. And I would do like the last 2 years over again in a heartbeat because of that, because it was actually like really helpful for me to go through that. So again, thanks to you for that. But if you had to go back and you were looking at my case, would you change the order of anything or have done it if again, surgery off the table? I know you would have
yeah,
probably preferred that I just have a surgery, but if that's off the table,
yeah.
what would you have done differently, knowing what we've learned, if you could go back and do it again?
The exact same thing that you would have done. For out of the gates, I would have done thyroid artery embolization exactly the reasons you're talking about, and also because we know that once you've disrupted the blood supply, once you reduce the blood supply, the ablation actually is much more effective because that blood has a tendency to dissipate the thermal energy and cool it down, so you can get a lot farther, with a lot less energy. Um, if you do the embolization first and the RFA afterwards. So that's probably the main difference that I would make. Yeah.
Okay. Yeah.
But otherwise, no, I think, look, and thanks to you, this has really been a journey. I've learned, I've done all sorts of stuff I never would have pictured myself doing, including strangulating thyroid tissue. Who knew? I've learned a lot about this, and it's been, a real nice partnership, and really I've benefited from this whole experience and continue to do so.
Mhm. Awesome. Yeah. Were there any points throughout this journey where you felt like we should just stop? Like, were there any points where you got scared with the progress or were really hesitant with our next steps, or any points where you thought that we should stop?
Yeah, I think every single time we saw each other and talked about a new ablation, I mean, I didn't push you towards surgery, but maybe I pushed you a little bit towards surgery. And I mean, it's deferential to what the surgeons thought. They just thought that you wouldn't do well with surgery. But yeah, I think so. I think I many times thought maybe this is enough of this.
Yeah, yeah. Thank you for your honesty.
Yeah.
I want to ask you a couple of other questions about just you as a physician. So, you have an incredible reputation. I don't know if you know this or not, but you have a really incredible reputation among other patients of having like incredible bedside manner, like exceptional. And so, I just wanted to hear your thoughts. Can you think of anything that you do differently or anything that you learned in your medical experience that you think adds to you being perceived that way and having that experience with patients?
Well, no, I appreciate you saying that. They don't let us on to the Facebook page, so I hadn't heard those, but that's really nice and nice to hear. So thank you.
Mhm.
Um, yeah, I don't know. I don't know what to say, but I mean, I can tell you when I was a medical student, we had a professor, an old guy who was in his 80s or something like that, and we were doing rounds, and he asked us was a group of medical students and interns and residents, who do you work for? And we all said, oh, we work for Harbor UCLA. That's where we were at the time, or we work for the UC Regents, or we don't know. We work for the state of California. We have no idea who we work for, But he said, you know, everybody, he belabored this question. He's like, no, that's not who you work for. No, that's not who you work for. And then, of course, at the end, he said, no, you work for the patient. Full stop. That's who you work for. And it's had an impact on me. And I think we all in medicine know that. Um, but I try to keep that front of mind. Ultimately, that's who I work for. That's who I advocate for. That's who I'm here for. That's, so that's one thing I think that informs the way I talk to patients. And the other thing, this becomes a very common question in medicine when it's no longer this situation where we're very prescriptive and tell you this is what you have to do, and I'm the doctor because I said so. But these become discussions about mutual decision making, and we're deferential to patients' preferences. But I often get the question, as many of us do, what would you do if this was your mother? It comes up, and my reply is always, that's how I'm thinking about this always. I only recommendations I make are recommendations that I would make to my mother. Fine, ask me, but I've already kept that again front of mind. So I don't know. Those are the things that try to guide my discussions with patients.
Yeah, that's really helpful. And I truly felt that through the process. I felt like you were like my biggest advocate in this whole process. So whatever you learned, you picked up, it's worth it. And then my next question would be like, what advice would you give to maybe like younger med students? And would you say it's really recognizing that relationship with your patient and treating them that way?
Yeah, I do. I think so. I think there's also, especially when you're starting out, there's this feeling or this pressure that you're supposed to know all the answers, and you're supposed to, if you don't know them, at least pretend that you know them. And I don't know that that serves anybody well. I mean, there's so much uncertainty in what we do that it's probably serves you as an individual, as a doctor, and it certainly serves the patient to say, I'm just not sure. And this is areas that I don't have experience, but I'm willing to ask around. And so, this is a humbling field, and there's no problem to be humbled by it. We should allow ourselves to be humbled by it.
Mm. Yeah, yeah. And I know we talked about this a little bit in the beginning, but I just want to go back now that we've, talked through the whole case up to date. And there may be another chapter, but where we are right now. Um, can you just describe, the emotional journey from a physician's perspective? I feel like this is just such an underrepresented aspect of it. It's like, what it's like for you to go through the ups and the downs. And, there was like successes, and then there were, moments when my neck opened back up again. And, all of that.
Yeah.
What was that journey like for you? And what kind of advice would you give to another physician going through that to just kind of like normalize the human experience?
Yeah, that's a good question. Unfortunately, most of these cases go without a hitch, and your experience is unique. And so that's great because this would be emotionally exhausting if this happened more than once in a blue moon. But I do think, um, again, I think I said it before. I think in the beginning, there's when you're starting in your career and you run into a problem, there's really feelings of self doubt and you have a crisis of confidence. And then, fortunately or unfortunately, old enough in my career where I'm no longer at the beginning stages, and I can say, you know what, these are just some of the unfortunate things that happen, but it's not because of a mistake that was made, and that's a nicer place to be in than having a crisis of confidence. And so, um, and then talk about it. I think nobody likes to talk. I mean, we're doing a study right now where we're looking into this complication, specifically thyroid nodule rupture. The reports in the literature are something like 0.5% of cases. I think that's vastly underreported. I think people don't want to talk about their complications because they feel shamed by them. They're traumatic, obviously for the patients, but also for the doctors. And so there's just a tendency to not discuss these things openly and out loud. We got so much to learn from one another. And so talking to other people, I guarantee another doctor will also have these same feelings of self-doubt, and it's therapeutic to talk about them. You also learn just an extraordinary amount from other people's issues, problems, complications, and so I think we're in a better place when we are upfront about these things.
Yeah, yeah. So communicating about it, talking, collaborating with people so you're not feeling alone in it. Are there any other like coping tools that you use as a physician, in general, maybe not just with my case, but with other cases too, when you have something that's more complicated or like difficult or is weighing on you? What are some coping tools that you may use to navigate through this?
Huh. That's a good question, Christina. You got your spouse. You talk to your spouse. Uh,
Mm.
and yeah, I don't know. I think talking about these things does help. Uh, yeah.
Yeah. And did this like teach you anything about yourself? I mean, I learned a lot about myself through this process, but like, did this teach you anything about yourself as you were kind of like navigating through this as well?
In what sense?
And like as like a person, like how like perseverance or like keep trying or collaboration with patients or teach you that you're more passionate, maybe about ruptures in general. And you're now doing a medical study at UCLA to help give some more education to this field. Like did this maybe push the envelope as far as what you want to do as a physician even, did you
Yeah.
learn something about yourself through this process?
Well, I think it reinforced some of the things that I already know, and one is that the relationship with the patient is important, and having frank and honest discussions with the patient is important, and not just for the patient's sake. I mean, certainly for the patient's sake, but for your sake as well. So that the decision making is joint, so that if you run into issues, you know that you fully explored the potential of those issues, and these things that are not things that you pushed the patient into, but you came to those conclusions together. I think that's something that I knew, but I think it's something that your case really uh, reinforces quite a bit.
Yeah.
Um, that's one thing for sure.
Yeah, I would agree. Absolutely. Um, is there any other like lessons that you learned, maybe then not personally, but more from a rupture perspective. So, one of them was we learned about silver nitrate, we learned about strangulation, maybe the steroids, or, is there
Yeah.
anything else that you learned maybe about wound care or, other things that were highlighted? Because we really did so many things that I've never heard anybody do. So
We did a lot.
I think people will be curious about the takeaways, like we've what have we learned? What would you
Yeah.
recommend or
Well,
insight?
first thing we learned, and I think we knew this, but there's really not a ton that's known about thyroid nodule rupture and its causes. We have some theories, and those theories are starting to mature and develop. But that's something that I've learned through this process with you. But this isn't not well understood complication. The treatment of it is evolving and getting perhaps better, but it's also not super well understood, and it's something that really we need to take more time to understand. Number one. Number two, it's not a complication that's well known about because it's rare, and so educating physicians on the signs, the symptoms in patients as well to recognize is an important thing, an important service to patients here because these things do come up with some frequency, and recognizing it earlier is better than recognizing it later. From what I am thinking now, probably being a little more gentle and less aggressive in the ablations, especially. Sorry, I timed out.
No problem.
I think I was saying so from the get-go for very large nodules like yours, being less aggressive out of the gates, maybe being more staged and deliberate about more gentle energy deposition is important as well. Early recognition, and I believe early sort of steroids and even sometimes prophylactic steroids, patients on who you've done a bigger ablation than you typically do, giving a few days of steroids. And patients are sometimes reluctant to take steroids. I understand that, but giving a few days might really calm things down and prevent these complications potentially. These are all wild guesses, but those are that's where I am. Those are some of the things.
Okay.
And then finally to the physicians, yeah, just don't wait and don't diminish and listen to your patients when they tell you something doesn't feel right. There very well be something that's not right.
Yeah. And what would your advice be to patients then? So say a patient is going through what they think is a rupture and they, maybe their physician isn't taking it seriously or isn't listening to the concerns. Is there anything that you could recommend from the patient perspective of how they could advocate for themselves if they think that they have a rupture? Like what can they do first? Or maybe their physician has never experienced a rupture before, kind of like my first time around. So what ways can patients advocate for themselves? We would love to think that the physician, knows how to
Yeah.
handle it. The information just isn't there. And frankly, most physicians haven't dealt with it before. So if a patient is going through this or they think that they're going through this, how would you recommend for them to advocate for themselves if their physician is maybe not versed in ruptures?
Yeah, and I'm hopeful at this point. I mean, we now have been doing this in the US for some time, and you know, I'm hopeful at this point that this is not just as obscure of a complication as once it was, and this is now on people's radar. We talk about this quite a lot. We go to these thyroid conferences, and everybody's got a case of a rupture, and it's the most dramatic thing in their thyroid life, and so they show it. And so I hope these things are better understood and better recognized these days. But sometimes patients are far more well versed in some of these complications, and so bringing it to a doctor, I hope, would be effective. Saying, "Hey, I am a little concerned about the course. This sudden swelling is not what I expected, and I've heard this might be typical of a thyroid nodule rupture. What do you think?" Just planting that possibility in their head. It might not be something that they've even considered. I think if you've never seen a rupture, you've never been involved with a rupture, it's easy to forget that that's something that actually happens. It kind of feels like you know, a non-entity because it just happens so unusually. So maybe bringing it to the patient's, I mean, to the physician, the patient bringing it to the physician's attention. That should not be the directionality of medicine in general, but sometimes it is, especially in these days. Patients are often, extremely well versed and well educated, well read on their conditions, sometimes more than the physician treating them.
Interesting. Yeah. Yeah. And so knowing everything that you know now and that there is a gap in the education or research for this, like in your ideal world, if you could wave a magic wand and there were education resources provided for physicians and patients, what would that look like? Like what should our goal be? Even if, it's maybe not attainable in the next couple of years, but say, 10, 20 years from now, what would you love to see in the realm of these thyroid procedures and thyroid nodule rupture particularly?
Well, I think the first thing would be understanding why this happens. We think it's an inflammatory response. Maybe there's delayed hemorrhage into the nodule coupled with, compromise of the capsule, but we're not entirely certain. But there's a lot of theories and how you can perhaps modify your technique. Some of the things we talked about, and some other things as well to diminish the risk of rupture. And right now, this is a black box. And, we are actively trying to understand this. There's a lot of people that are actively trying to understand this, and I'm quite sure we will. This will mature to a place where we understand better who's at risk, who's not at risk, and what techniques put you at greater risk. So that's the first thing is just the research aspect of it, and that's trying to prevent it, which is ideally where we are, and then trying to recognize it. I hope that that just becomes commonplace. That as people do this more, this just becomes one of the things that they is on their radar and they know it. And then the treatment algorithms, those are also things, went from being oriented around early interventions and sucking out pus and worried that this is infected because it looks like it infected, to us moving towards a place where management is much more conservative, much more hands off, much more oriented around supportive care and letting the body do its thing. And so, is that the right thing? I think so, but defining that in a more rigorous, scientific based way is what we have to do. Taking all of the ways that patients have been treated and finding the ones that truly were most effective. And that's only going to come from time, from experience, from aggregating people's experience so that we have some sort of evidence-based scientific conclusion.
Yeah, yeah, that that would be beautiful. And more patient, resources as well, like I'm sure would come with all the education. And so branching off in that direction, so you're actually a part of that right now. Would you mind just sharing about, the study that you're working on right now, and maybe if anybody can get involved or if there's any call to action that, patients or physicians can participate in these surveys? I know I
Yeah,
have a link on my website, thyroidrupture.com, but do you want to talk a little bit about the research that's already underway right now?
yeah, I'd love to. I think so. Our research, and we've been doing this for perhaps a year or so, is we're trying to understand this for all the reasons that I talked about. And we have two components. One is understanding sort of the physician's experiences and trying to collect. There are publications in this domain, but we're trying to aggregate bigger experiences and not just looking at the patients that rupture, but looking at the patients that rupture compared to all the patients that are treated. Is it more common in this group of patients versus this group of patients? So that's one of the things that we're doing is we're looking at the physician experiences and trying to collect data on that end. And then the other thing, which I don't think much has been discussed, but is looking at it from the patient point of view, is, and a lot of things you've helped us to develop, trying to understand for the patient point of view, what's the timeline for when they were diagnosed, what have their experiences been like, and patients are sitting obviously with their nodule rupture. They know more than anybody about what their experience has been like and what was effective or what they think is effective and what's not. And so trying to aggregate those experiences also in a bigger way, not just in an anecdotal way, but in a bigger way so that we understand it from the patient point of view. That's what we're working on right now. We have some really good data that we're starting to compile and hopefully get out there into the world soon.
Awesome. Yeah. So if you're a patient watching this and you've had a rupture and you want to fill out the survey, it only takes about 15 minutes or so. And there's a link on thyroidrupture.com. And if you're a physician, how can they get a hold of that survey if they'd like to participate?
That's a good question. I don't know that the survey is right now available except for me sending it to people, but we'd be, certainly by email, you can email me and I'd be happy to send out the survey link. And we're always interested in collecting additional data.
Okay, awesome. So we've covered a lot. This is like my whole experience. I'm so grateful for all of it. But I want to see if there's any other final takeaways, anything that we haven't covered that you think would either be, helpful to highlight, anything unique about my own case study journey, or just in general, if there's another patient who's going through a rupture, a physician who's, experiencing a patient with a rupture, anything else that you feel like you could add to this discussion that we didn't already cover.
No, I think we're now in a place where this world is much smaller and there's a lot of resources for patients. You in the Save Your Thyroid Facebook page, and there's just a lot of inter-patient education and communication that's going on, which I think is really, really great. And then on the physician end, this is also a very small world. We interact with one another, and I think we're all open. People that are passionate about this are all open to talk to one another about our experiences and help guide each other through. And um, in the early parts of when I started doing this, I certainly had a lot of very generous mentorship, and I'm happy to provide whatever advice I can to other physicians, as is I think many people in this space. So don't hesitate to reach out on any level. I think we're all in this, together, and so use each other.
Awesome. Yeah. Yeah. I think collaboration is key. So I again appreciate your collaboration and thank you so much for taking all of this time to go through it. And not only for just today, but honestly, from the bottom of my heart, for the last couple of years, everything that you've done, you've literally changed my life and you've been the most extraordinary physician I could have ever have asked for. And so I just want to personally thank you for everything. You've been incredible, and I'm just so grateful. And thank you for continuing to support other patients in the future and provide these resources and education and adding to the field. It's just so appreciated and needed. I'm just so grateful. Thank
I
you.
appreciate it. Now it's been my pleasure. Thank you.